Hi guys, Laura Healy, nurse practitioner, medical oncology. Just a quick overview or update on superior vena cava obstruction, SVCO, one of the oncological emergencies, and just going to look at an introduction to the superior vena cava and its obstruction and why it's so important to identify and manage. So SVC, the SVC is actually one of the largest veins in the body, and it's described as a major vein. And it actually collects deoxygenated blood from the upper half of the body, so the head, the neck, upper limbs, and the chest wall, and it transports this blood to the right atrium of the heart to be oxygenated via the lungs, and then sent to the left ventricle, so it's pumped out to the rest of the body. It's roughly positioned at the second costal cartilage, where it enters the middle mediastinum and it becomes surrounded by fibrous pericardium, and it's about 2 centimeters in diameter and 7 centimeters in length. So just to quickly recap, oxygen poor blood returns to the right atrium from the body through the superior and inferior vena cava. The right atrium then pumps the blood to the right ventricle. The right ventricle then pumps the blood to the lungs via the pulmonary artery to get oxygenated. Then the oxygenated rich blood returns to the left atrium from the lungs through the pulmonary veins. The left atrium then pumps it to the left ventricle, and the left ventricle pumps the oxygen rich blood to the body through the aorta. So just a little bit of anatomy again, just to get where the positioning of the SVC is to understand why obstruction is so important to be identified. The SVC is formed by the junction of the left and right brachiocephalic veins. It arises from the joining of the two of them, and it's at the junction of the second costal cartilage. It descends vertically through the superior mediastinum, which is behind the intercostal spaces, to the right of the aorta and trachea, and it terminates by emptying into the superior aspect of the right atrium at the level of the third costal cartilage. And that's just a little pictogram there defining that. So patients presenting with SVC obstruction or SVCO, it actually depends on the speed of which the onset of the SVCO, the severity, how badly obstructed the SVC is, and the location of the obstruction. So there can be swelling of the face, neck, and the upper extremities. There can be collateral drainage, which is actually the distended veins in the neck and the chest, and that can develop over time. It can be a slow obstruction, and patients may actually have no symptoms or only mild symptoms. But if it's an acute onset, which has happened rapidly, then symptoms can include that facial edema, facial swelling. They can have plethora, which is and it just blood basically. It can be pooling in the veins. They can have that subcutaneous vein engorgement in the head, neck, and chest regions, which is the distended veins, that collateral drainage that happens. They can be short of breath. They may need to sit upright. They can have dysphonia, so they can have changes to the voice. They can be cyanosed, so they may look that little bit of a tinge of blue or a little bit of a dusky pink or kind of grey look about them. They may actually feel full in their head, especially more so when they lie down or bend forward. They can have a stridor, which is actually a respiratory distress, so that's when they're trying to do that inhalation and exhalation, and they cannot complete a full sentence due to the blockage or the increased pressure of the breathing. And they're using their accessory muscles, so they may look uncomfortable, and they may be tachypneic, so increased respiratory rate. There can be confusion that can set in because of that altered blood return to the head, and they can have seizures, and that can actually indicate cerebral edema, so that swelling can actually happen up inside the brain as well, and that's quite worrisome, especially that in conjunction with a stride or a hoarse voice. It actually the hoarse voice in stridor indicates laryngeal edema, so there's increased pressure and swelling within the anatomy, and a confusion is particularly worrisome in case they have cerebral edema. So this next picture actually just shows that facial flushing, more so around the eyes, and that edema around the periorbital edema around the eyes, and they can have that plethora where they're a little bit more red, where they've got more blood supply, and that can be due to that compression of the SVC by either a tumour, which can come from the main or upper lobe bronchus, or enlarged lymph nodes in the mediastinum, so the centre of the chest wall, and that can be a diagnostic sign looking at the patient's face. As we said, also there can be that collateral veins. So this is a picture of a pacemaker thrombus where the arrow is actually pointing to the blockage in the drainage system, and they've got distended in that picture in the B where they've got that blue veins that you can see. That's the descended veins across the anterior chest wall, and that facial plethora where they've got that redness and swelling within the face. And the next picture is actually a picture from malignancy, where the patient has a cancer causing the narrowing and blockage, which is mostly seen in picture D, where in the right upper lobe they have a mass which is causing compression or narrowing of that SVC due to the size of the mass pushing against it. As you see in picture A, the patient has redness from the chest up to the face, and in picture B there are a few little veins starting to pop out in that décolletage on that chest wall, and C is actually just another picture of the scan to show what is actually going on. And this was a paper I found just while I was researching, which shows a goiter from thyroid dysfunction, which is actually causing blockage of the SVC as well. So not always malignancy, there can be other reasoning behind the SVC obstruction. However, just highlights that simple as what we think about thyroid dysfunction can actually result in a real emergency for the patient themselves. This is a picture that's all over the internet when you actually research Pemberton, and Pemberton is a clinical sign that's used to help diagnose an SVC obstruction. It is when you ask the patient in front of you to put their hands up above their head. The change in the position indicates vessel compression, and they can actually have that change in colour, that facial plethora and swelling, and that's an indicative clinical diagnostic sign for a positive Pemberson's, with the picture on the right with the facial redness, with the hands up above his head. And as you can see, comparing that to the picture on the left, when his hands are down, his facial colour looks pretty normal. So that would be a diagnostic sign that we use in clinic. So causes of obstruction. Nowadays it's normally seen, as we know, secondary to malignancy, but there are other, as I've said previously, benign reasoning behind it. So malignancy such as non-small cell and small cell lung, lymphoma, because they can grow quite big quite quickly, and they can press on or grow into the SVC. Thrombus again, so a clot can form in the SVC and cause that compression. So anyone with a central venous catheter can have an increased risk. Anyone who's had radiation therapy to the upper lobes as well, or that chest area, especially the mediastinum, we can have scarring and narrowing of that SVC post-radiation to that area. Infections, actually, such as TB, can cause inflammation of anatomy and then obstruction. Aortic aneurysm, which is a widening or a dilated veins of the aorta, can compress the SVC because of the backflow and the pressure that can happen. And then constrictive pericarditis, Um, the pericardium, that lining of the heart, becomes inflamed, thickened, and tight, and that can cause compression of the SVC. And as we've showed earlier in a picture, that enlarged thyroid gland, that goiter, can actually cause compression as well. But I think most of the patients that we see, as we know, are due to um, locally advanced metastatic cancers when they present, unfortunately. So pathophysiology, so the mechanisms that actually lead to that increased pressure in collateral vein is the increased blood volume due to the inappropriate draining of the SVC. So there's more fluid, the vessels are larger and there's higher pressure. So there's more blood volume trying to pass through that area, and it ends up making its own pathway to find another way to get past the blockage, and that can cause that. The tighter veins, when veins lose their ability to stretch, often due to stress response, pressure goes up and can block the veins, and we can have obstructions from such things as tumour or clot, as we've said before, and that stops the flow and that causes a pressure build-up. And if we have any heart problems or left or right-sided heart failure or dysfunction, when the heart isn't pumping as well as it normally should, the blood backs up and this pressure then that ends up backing up again into the veins. And the collateral circulation actually becomes evident after our body will actually come with has some extra vessels there, so it can develop its own new pathway, as I've said, due to the blockage, and it's in a response to that blockage of the blood flow, and then it can actually grow new vessels to bypass the problem. And when the main vessel's blocked, these collateral veins or vessels will step up to take the extra blood flow, to handle that extra blood flow, to keep that circulation in check so that it's still managing its normal abilities. So for diagnosis, we would normally diagnose on a CT scan. Sometimes there is an MRI depending on what we're looking at. So there is mediastinal widening or like pleural effusion on a chest x-ray, then we'd probably go to a CT scan. And we'd want to look at that to check for vena cava patency to see that the blood actually flows through properly. And then an MRI may end up having to be done if it's the thyroid, if we're worried about the thyroid, or an ultrasound, and then also on the patient's own clinical signs and symptoms, like we've discussed, like the Pemberton's, the facial swelling and plethora, and the collateral veins. So this was just a picture to look at anatomy, to try and discern where a blockage may be. So the upper photo is the CT scan. The bottom photo is a diagrammatic view of the heart. So in the CT scan, we see the cancer pointed to by the yellow arrow, with above it and below it the superior vena cava, which is actually being narrowed underneath it, so that then will affect the blood supply. And as you can see on the diagrammatic photo, it's showing you actually where the cancer is in relation to the other image. This again is another picture showing a CT scan coronal plane with a clot, which is really hard. I should have put an arrow on it, I'm sorry. And it's actually an occlusive thrombus in the superior vena cava, and it's actually extending into the heart. And it's got some mediastinal lymphadenopathy, which is over on the left hand side, and we've got a little bit of push of the trachea across to the right as well. Here again we've got just some other pictures. So this is a slice of a CT scan, again showing that on the, as you look at the screen on the right hand side, we've got a fluid collection, a pleural effusion. And then on the left hand side, the arrow's pointing to the thrombus, which will be causing the backflow, which can be causing the pleural effusion also. So it's can cause quite a lot of issues with the patient, especially respiratory and cardiac, but also there's some dilated veins within this is pointed out, and they can then start to look at that collateral veins and system they need for doing drainage. And this one, there is a large mediastinal mass. So on the left hand side of the screen, you can see a pleural effusion again. So we've got some fluid collection on the left hand side. There is a tiny bit on, there is a tiny bit on the left hand side on the bottom, but on the right hand side there is a large pleural effusion. Where you have them in the middle of the screen, where there's the two little dark bits that reach together, there is complete obstruction there from cancer. That whole area in the middle here is a tumour in the mediastinum, which will be blocking the superior vena cava as well. And there's some consolidation in the bottom of the lung as well, unfortunately. So treatment options, this is an emergency because it can deteriorate very quickly, and we really want to relieve the symptoms to improve the patient's quality of life and address the underlying cause of the obstruction, which in our case is normally mostly cancer. And we want to look at corticosteroids, so we want to be starting dexamethasone to reduce the inflammation and the swelling around the SVC, to improve symptoms such as that shortness of breath, to reduce the pressure, and that's normally 8 milligrams of dex twice a day until the patient's symptoms are improving or other interventional procedures are put in place if appropriate. So then we would be looking, if there is a thrombus, to look at anticoagulation. We would look to ask our hematology colleagues as well, thrombolysis or a thrombectomy, depending if the patient's fit enough and well enough and if it's deemed appropriate. We'd want to be looking at liquid morphine. I know Ordine's not available, but Oxynorm at the minute, to help relieve and alleviate the symptoms of the shortness of breath, and to talk about other options like a fan, window open, oxygen if required, depending on the patient and their vitals. We would also speak to our radiation colleagues for radiation to the area to reduce that obstruction, especially if it's from a malignancy. We'd also want to start treatment as soon as possible, if appropriate for the patient, to help alleviate the underlying cause, which would be the cancer. We can get a surgical opinion on stenting of the actual superior vena cava. Is that appropriate, or is surgery appropriate, which it depends on what the cardiothoracic surgeons think is appropriate, and the patient as well, their comorbidities, their ECOG at presentation, their underlying cancer, and what is their treatment goal and options. So for us, it's really about, if the patient's admitted, then assess and monitor their vital signs. We'd want to be looking at their respiratory rate, their oxygen saturations, the use of accessory muscles, any dyspnea, that dysphonia, the change in the voice, and what's actually happening to them. Are they actually feeling any better as treatment goes on? So that's the respiratory status. Assess and monitor the swelling. Is it alleviating? Do they look any better? Is their face going down? Has the collateral vessels started to recede, or how are they presenting? Pain and discomfort, obviously, because of everything else that's going on, there is associated pain could be from the pleural effusion, pleural irritation, but also from that use of accessory muscles. When we're nursing them, if possible, then nurse them with the head of the bed up, or they may actually be more comfortable in the orthoptic position. Make sure we've got medications charted, provide emotional support and education, but it's also about when they do go home to make sure that they're educated on the signs and symptoms, when to report, when to present to ED, all red flags, and ensure that they've actually got a follow-up appointment. There can be also ongoing issues from the risk of like cardiovascular collapse, so cardiovascular tamponade, that central airway obstruction if it's not dealt with, laryngeal dysfunction ongoing if there's complete compression, and actually associated respiratory failure, unfortunately, if the symptoms are not dealt with and the underlying issue. So any questions, then please send me an email, laurie.haley@calvarymartyr.org.au. I think I've got a few other little. The EVQ has got a very excellent online resource and rapid learning evaluation for superior vena cava obstruction, which I'd recommend anyone to go on and do. There's some references here as well. That was just a little update, again, reminder on the blood flow and cycle, so that everyone remembers, and to look at the anatomy. And also that was grading, but we don't normally grade so much, as we normally just get the patients in and start any treatment that we possibly can, and then obviously like dexamethasone and pain management and supportive medications for that shortness of breath, but then also review the patient with regards to what treatment options can we actually do as well. So it's all about symptom control safely. Okay, thanks guys, take care, bye.